I'd like to call the meeting of the Military Construction, Veterans Affairs, and Related Agents Subcommittee to order. Thank you all for participating in this hearing on women's health, mental health, suicide prevention, whole health, and homelessness at the VA. Before we begin, as this hearing is fully virtual, we must again address a few housekeeping matters. For today's meeting, the chair or staff designated by the chair may mute participants' microphones when they are not under recognition for the purposes of eliminating inadvertent background noise. Members are responsible for muting and unmuting themselves. If I notice that you have not unmuted yourself, I will ask you if you'd like the staff to unmute you. If you indicate approval by nodding, staff will unmute your microphone. I remind all members and witnesses that the 5-minute clock still applies. If there is a technology issue, we will move to the next member until the issue is resolved, and you will retain the balance of your time. You will notice a clock on your screen that will show how much time is remaining. At 1 minute remaining, the clock will turn to yellow. When your time has expired, the clock will turn red, and I will begin to recognize the next member. In terms of the speaking order, we will follow the order set forth in the House rules, beginning with the chair and ranking member. Then members present at the time the hearing is called to order will be recognized in order of seniority, alternating between majority and minority. And finally, members not present at the time the hearing is called to order. Finally, House rules require me to remind you that we have set up an email address to which members can send anything they wish to submit in writing at any of our hearings or markups. That email address has been provided in advance to your staff. Today, we welcome back to the subcommittee Dr. Cameron Matthews, Assistant Undersecretary for Health for Clinical Services at the Veterans Health Administration. She is accompanied by Dr. David Carroll, Executive Director of the Office of Mental Health and Suicide Prevention at the Veterans Health Administration. Excuse me. Dr. Patricia Hayes, Chief Officer, Women's Health at the Veterans Health Administration, and Ms. Laura Duke, Chief Financial Officer at the Veterans Health Administration. Today's hearing will cover some of the areas of care at VA that are essential to veterans' overall well-being. Women's health, mental health and suicide prevention, whole health and homelessness are some of the program areas that this committee has prioritized improving and expanding. And I know we're all proud of the work that we've done to achieve that. This hearing will give us a chance to receive an update on how those efforts are going and what we should be looking to pursue in the coming fiscal year. Of course, once the President's budget is released, we'll have the opportunity to dive further into the questions of future funding in these areas with the new Secretary when he comes before our committee. But in addition to investing the resources to help these programs succeed, this committee is also focused on oversight in each of these areas, and such oversight simply cannot wait. There is too much work to be done to ensure that our veterans are receiving the services they need. These programs all come together to help VA provide care and services in the comprehensive fashion that is required in order for veterans to achieve the best possible health outcomes. All 4 programs received increases over the prior year in the FY 2021 Appropriations Act. For example, the Appropriations Act enacted in December provided nearly $661 million for gender-specific care for women, a historic high that reflects the need to support the fastest growing group of veterans at the VA. In fact, women's health at VA should not be considered, in my view, specialty care or a nice bonus in some facilities. It should be built into the system at a fundamental level and put into practice consistently across the VA healthcare system. If we want to encourage women veterans to receive their care at VA facilities, we need those facilities to be properly staffed with women-specific healthcare providers and support teams, and to offer visible programs and services that address healthcare challenges facing women. Women need equitable access to VA healthcare services and programs, but they also have unique needs and benefit from tailored programs. Areas like maternity care, gynecological care, and treatment for gender-specific conditions and diseases have benefited from an increased focus at VA, but we want to make sure that we keep making progress and move forward. Likewise, we need to make greater progress with VA's mental health and suicide prevention programs. The rate of veterans dying by suicide is still deeply troubling, as it continues to remain stagnant when it should be decreasing. What also concerns me is that data used in VA's annual study is actually 2 years old. We aren't even getting a full picture of the current state of veterans dying by suicide. I know the VA has been applying several proactive approaches to try and reduce these numbers, such as seeking to keep veterans connected during their transition from active duty, identifying veterans at risk of suicide, and strengthening outreach and contacts to veterans. I look forward to hearing more about these efforts and others underway to prevent suicide, as well as to make sure that every veteran who seeks out mental health care is getting it. No one should be turned away from care, and we need to also make sure that care is of the highest quality. We are committed to ensuring that resources are available to strengthen mental health programs and reach every veteran in need. In FY21, we provided more than $10 billion for mental health programs and specifically directed funds towards suicide prevention. These funds will help expand what's working and target gaps in current efforts. This is why I'm also so excited about the Whole Health Program, which supports a model of care that goes beyond treating the physical symptoms of diseases and works to personalize healthcare plans for veterans that consider the physical, mental, emotional, spiritual, and environmental needs of veterans. I'm optimistic that this model can help with a wide variety of veteran healthcare challenges like mental health, and I'm glad that VA has also seen the potential in this program. And finally, one of the most persistent challenges facing the VA is that of veteran homelessness. VA has made notable progress with the number of veterans experiencing homelessness declining by nearly half since 2010. But there is still more work to do, especially in light of the pandemic and its related challenges. The CARES Act enabled VA to direct $971 million to help homeless veterans impacted by the pandemic, and also provided new authorities for VA to adapt its homelessness programs to this crisis. The American Rescue Plan that passed earlier this week and is now law, thanks to President Biden's signature yesterday, includes funding to ensure that VA has the resources needed to continue these efforts moving forward. Pandemic or not, we must pandemic, the wonders of modern technology. Pandemic or not, we must continue working to reduce veteran homelessness and prevent veterans from sliding back into homelessness. All four of these programs are at critical junctures. They will continue to be among our top priorities in this subcommittee for ensuring veterans' health, and I look forward to hearing from our witnesses about the work being done in these areas and what lies ahead. I'm now pleased to yield to our ranking member, Judge Carter, for his opening statement. Judge?
There you
go. Thank you, Madam Chairman, for calling this hearing today. The VA specialty programs are very important to our veterans. This allows us to dig into some issues that we may not be able to do in a regular budget hearing. I think we all appreciate the opportunity to conduct oversight on veteran healthcare issues. Oversight is missing in many instances, and we, I think, do a good job of oversight, and I congratulate you for it. The testimony VA presents today rightly highlights its notable accomplishments in areas such as whole health and care for women veterans. VA even made progress, especially in telehealth, and over the past year, while engulfed in this pandemic. Of course, there's always more to be done and improvements to be made. Before we get into those, let me express my appreciation to Dr. Matthews, as well as the other witnesses today, and all of the VA doctors, nurses, and staff for the hard work and dedication to veterans. On a daily basis, you show this nation values that we consider their sacrifice and service. Before I go, I want to let you know I just received a note. I never know for sure whether everybody sees my APAC representatives when they come to town, but Roger Stouffer has become over the last 20 years a very good friend of mine. He always visits me from APAC. And Roger passed away yesterday, and his funeral is actually, in fact, going on right now as we're holding this hearing. Roger was a guy that could take serious issues and convince you of them, but he also had this fantastic humor that would always brighten your day. And so I want to tell, if anybody knows Roger Stouffer, if he ever visited you with APAC, we lost a really good man to leukemia. Thank you, Madam Chairman, for allowing me to do that. I yield back.
Judge Carter, in my faith tradition and in Roger's, may his memory be for a blessing. And we are sorry for his loss and appreciative of his commitment and support for the state of Israel and the U.S.-Israel relationship. Okay, I don't believe either Chairwoman DeLauro or Ranking Member Granger are here. So Dr. Matthews, you'll be the only, my understanding is you're the only one that is actually going to be completing testimony. Your full written testimony will be included in the record, and you are now recognized for 5 minutes to summarize your remarks.
Thank you. Good morning, Madam Chair, Ranking Member Carter, and distinguished members of the subcommittee. My colleagues and I appreciate the opportunity to discuss how VA provides a unified approach to veteran care by leveraging all of our capabilities, including those in women's health, mental health, homelessness, and whole health. I'm accompanied today by Ms. Laura Duke, Chief Financial Officer, Dr. Patricia Hayes, Chief Officer of Women's Health, and Dr. David Carroll, Executive Director of our Office of Mental Health and Suicide Prevention. Our commitment at VA is to promote, protect, and restore veterans' health and well-being, to empower and equip them to achieve their life goals, and to provide state-of-the-art treatments as needed. VA provides a continuum of forward-looking outpatient, residential, and inpatient services across the country. Services are integrated in order to assure that the veteran is at the center of their care and that she or he receives those services when and where they are needed. Both physical and mental health issues, including opioid and other substance use disorders, require overlapping, integrated, and veteran-centric approaches to treatment, as well as those services that address their associated social needs in order to prevent poor outcomes. With your guidance and support, VA has worked diligently to address one of the most pressing social needs, that of homelessness amongst veterans. VA used the CARES Act provisions to fund programs to help our veterans experiencing homelessness or housing insecurity. The Supportive Services for Veteran Families program received $716 million to provide emergency housing and homelessness prevention assistance to mitigate the expected wave of evictions and potential homelessness that would have resulted from extensive unemployment during the pandemic. The emergency housing assistance included over 24,000 hotel or motel placements that occurred since April of last year through January of 2021, reducing the risk of COVID-19 exposure for those vulnerable veterans. However, it doesn't end there. VA has conducted COVID-19 testing with over 7,000 veterans entering its residential programs and has now vaccinated over 19,000 homeless veterans overall. The Grant and Per Diem program received $170 million to support per diem increases to expand services and also reduce risk of exposure in congregate settings. And finally, VA used CARES Act funding to purchase and disseminate over 28,000 smartphones for homeless veterans to facilitate virtual access to providers, prospective employers, and landlords. Taken together, VA's efforts with homeless veterans have addressed not only the emergency housing needs, but their broader social, physical, and mental health needs. VA is leading the nation in the transformation from a system designed around episodic points of care focused on disease management to one that is based on a partnership between the veterans and the VHA across time, focused on lifelong health, well-being, and resilience of veterans. The whole health outcome evaluation at our initial flagship facilities, which were mandated in the CARA legislation, demonstrated more rapid decrease in opioid utilization and improved quality of life, as well as an increased sense of meaning and purpose in life among those veterans utilizing the whole health approach. Based on this successful effort and building on the experience at the 18 flagship sites, the system-wide rollout of whole health is well underway with an emphasis on integration of the whole health approach into all primary care and mental health clinical settings, with the ultimate goal being a seamless incorporation into all VA services. The current phase of the rollout includes 37 additional VAMCs that are initially focused on evaluation of specific dimensions of the whole health system. More women are choosing VA for their healthcare than ever before, with women accounting for over 30% of the increase in veterans enrolled over the past 5 years. The number of women veterans using VHA care has more than tripled since 2001. To address the growing number of women veterans who are eligible for healthcare, VA is strategically enhancing services and access for women veterans by investing $75 million in a hiring and equipment initiative in 2021. VA provides many services for women veterans, including women-specific areas of gynecology, maternity care, infertility services, and mental health services in order to assist with military sexual trauma. To provide the highest quality of care, VA offers women veterans assignments to trained and experienced designated women's health primary care providers. The providers offer general primary care and gender-specific primary care in the context of a longitudinal patient-provider relationship. National VA satisfaction and quality data indicate that women who are assigned to women's health PCPs have higher satisfaction and higher quality of gender-specific care than those assigned to other providers. Importantly, we also find that women assigned to these care providers are twice as likely to choose to stay in VA care over time. VA's goal is to meet all veterans where they are in life and walk with them to ensure they can achieve their goals by teaching skills, connecting them to resources, and providing them with the care that they need along the way. Our objective is to give our nation's veterans the top quality experience and care they have earned and deserve in an integrated and seamless manner. This concludes my statement. We're very eager to take your questions. Thank you.
Thank you so much, Madam Secretary. Appreciate your work and look forward to talking with you and your colleagues. You know, when we're all working from home here, we have to be staffed in unique and different ways. I was just staffed by my youngest daughter, who brought me a pen. So, so forgive me for the interruption. I assume that that Ms. Hayes will likely need to answer at least my initial questions, or we'll get assistance from her. But I understand there's been a reorganization within VHA that elevated the Women's Health Office, which I was thrilled to hear, to report directly to the Undersecretary for Health. Can you talk a little bit about the impacts of that change? What does it enable? When did that happen? What does it enable the office to do more effectively? And frankly, that's a really, I think, such a huge move from when I became initially ranking member and then the chair of this subcommittee, because it really felt like the women's health program was a stepchild at the VA, and this is really, I think, a significant move.
Dr. Hayes, I'll let you take that directly.
Whoever,
Yes. Good morning, and thank you very much for having us and for allowing me to be part of this hearing. It is very important that VA was able, through modernization and through your encouragement from Congress, to elevate the Office of Women's Health from further down in patient care services, where essentially I had 3 supervisors above me before I saw the Undersecretary, to a direct report to the Office of the Acting Undersecretary for Health. That obviously gives me direct lines of communication to be able to discuss the important needs and impacts and gaps in services for women veterans. So I do have direct access to the Undersecretary as my supervisor, but also in terms of regular, very regular meetings, emails, and conversations. We've been able to move our, and I should note, as you asked, that happened in January of 2020 and was formally made really effective when we got our complete budget at the beginning of this fiscal year. Was all the other pieces in HR were all transferred over with this sort of more seamlessly at the beginning of this fiscal year. That allows me to make direct recommendations through him to the network directors, and really to have a constant kind of performance evaluation of how we're doing on filling the gaps for women veterans.
Have you been able to see the impacts of that change just yet? What would it enable you to do more effectively, would you say?
Pardon me. I think we were able to roll out the initiative, which we'll be discussing in terms of the number of millions that we've put into hiring and equipment this year. We were able to start that by getting his approval to help with getting funds out October 1st. So I think those kinds of things that normally would have had to go through more chains and more signatures have been expedited.
Fantastic. Back in 2015, the VA published a study that looked at barriers to accessing VA care for women and how these barriers were experienced by women veterans. And I know that study has informed a lot of the VA's planning for your gender-specific healthcare. Has the study been updated since? Are there plans to update it? And how are you ensuring that you're keeping your finger on the pulse of what women veterans want to see at the VA, especially given that they're the fastest growing population of your patients?
The study is set to be updated for a number of reasons, but particularly because of the Isaacson-Rowe 2020 Improvement Act that requires us to redo the study, so that we're in the process of getting that set and ready to go. But there are a number of ways that we can pay attention to the feedback from women veterans. Regular focus groups at every facility, at least quarterly, are now underway. Also, what we call V-signals, which goes out to 150,000 veterans on a regular basis. We're able to look at that by gender and location and drill down to veterans' concerns and feedback, positive and negative, at a local level. And we regularly do that with our women veteran program managers.
That's great. Lastly, before my time runs out, we held a hearing, you're probably aware, earlier this week about the access to in vitro fertilization services at the VA for our veterans. You know that veterans are, the VA is currently tied to a Department of Defense regulation on IVF that is nearly a decade ago. It shuts out veterans who need donated sperm or eggs. So shuts out same-sex couples and unmarried couples, among others. How would decoupling the VA from the DoD policy allow you to provide IVF to more veterans whose service-connected disabilities prevent them from conceiving?
Thank you. That's such a critical issue for us. The current policy, as you've outlined, has some restrictions in it which are antiquated and just simply unfair. We want to be able to work with you so that VA can, through legislation, establish VA's own policies to open up the eligibility for veterans who would like to build families. I personally have talked over the last year to probably 60 veterans for whom the IVF current regulations close them out, and most heart-wrenching and distressing conversations because of the ways that the regulations have had to been formulated. I want to work very closely with you and other members of Congress so that we can fix this and invite veterans into full IVF and other fertility care.
Thank you so much, Ms. Hayes. We want to work with you as well, and just so appreciate the incredible work you've done, and Secretary Matthews, you as well. Thank you so much. My time's expired, and I'll yield to Judge Carter for his 5 minutes of questions.
Thank you, Madam Chairman. Dr. Matthews, back home here in Texas, I hear a lot of concern about burn pits and other toxic exposures. Can you tell us about the clinical symptoms of a veteran who's been exposed to an open burn pit or other toxic chemicals? What would they exhibit? What kind of symptoms? And what treatments are available?
Sure. Thank you for the question, sir. This is definitely an area I know of great concern for many veterans because unfortunately there's a great range of symptoms, sometimes being quite subjective, meaning they just feel they can't exercise as well, they can't get the air in, all the way up to coughing, wheezing, shortness of breath, which actually is a lot like asthma. So there's even a lot of confusion there. Treatments vary. A lot of them are very much symptomatic. If indeed it is looking, at least per testing, that it looks a lot like asthma, we do have, of course, very typical treatment courses there. But unfortunately, for those more subjective symptoms that they have, we don't have a lot currently that the evidence shows. That doesn't mean that we wouldn't necessarily attempt other options that may help the veterans feel more comfortable. But there is a great deal of research coming out of the center in New Jersey to look at exactly this. This is equally as concerning for us.
Are your clinicians, are they trained to spot this burn pit issue, because it's really a hot topic among veterans right now?
So they are trained and expected to definitely question a wide range of symptoms. With those symptoms, yes, they then make referrals over to our environmental health teams. Every facility has a clinician and even program coordinator that is actually responsible for doing the full registry exam. Once the veteran's on the registry, there's regular, even annual involvement. We even created an app called the Exposure Ed app to help, even if the primary care doc before the referral has questions, to walk through the app with the veteran. Community providers can use it as well, and we definitely promote that through our networks. So while the formal training, it's 3 rather long modules online, that's usually taken by our environmental health docs that are doing the more formal exams. The information is available, and again, we do have the apps available to even simplify the process.
Thank you very much. Do you help the veterans determine service-connected ratings? Does the VA help them with that?
So that we, of course, perform a proportion of those exams through the comp and pen exam work that we assist VBA with, but we're not the docs that are actually making the decisions about percentage connection in which they actually declared. We assist with the physical exams and then hand that information over to VBA.
Thank you. I have a little bit more time. Let me ask you, over the past couple of years, there's been a growing interest in using artificial intelligence to predict and prevent suicide. The House report and conference agreement included report language on the issue. How is the VA using these technologies?
Dr. Carroll, do you have information on that?
Yes, good morning, and thanks for the opportunity to participate in this hearing today, and we appreciate your support. So the thing that I would talk about first, Ranking Member, is our REACH Vet program. It uses predictive analytics to look at veterans who are enrolled in VHA care to identify those who, from a statistical point of view, may be at the highest rate of predicted suicide risk. And then our teams share that information with the providers at the local facilities, who then review the record and reach out to veterans and ask what more can we be doing. This gives a signal to the provider to make sure that they're examining the care that's provided and to step up that care in any way that's important for the veterans. We have seen increased engagement in care following these kinds of contacts, and there's been a reduction in all-cause mortality for those who we have engaged in this process.
So are you working with the VSOs, veteran service organizations, and technology companies to get their input?
Yes, we work with the VSOs on many fronts to make sure that there's messaging going out about the resources that are available to VA, and we are working with partners across the federal government and in the private sector on advancing all of our work in social media and other forms of communication and technology platforms.
It seems, at least, that we in this modern day, suicide is becoming almost epidemic, not just among our service personnel, although it is there, but also across the board. And I'm not sure whether, I'm always never sure whether we've got better reporting so the public knows more about it than in the past, whether it's a real epidemic, but it certainly seems to be. And I know the Army has a whole department that just looks at suicide. I thank you for what you do. This is a very, I think, complicated area to work with people who are considering suicide. But it seems to be right now epidemic across the board, even in our schools. So you're very important to this country. Thank you for what you do. I yield back.
Thank you.
Thank you, Judge. Now I'd like to call upon Congressman Case for his 5 minutes of questions.
Thank you, Madam Chair. Dr. Matthews, or whoever you want to refer this to, can I talk with you a little bit about veterans homelessness? Yes, there have been great strides made. Still, way too many veterans homeless, and as you know better than me, disproportionate veteran populations are impacted by homelessness, particularly true in my home state of Hawaii, where it's a very difficult homeless issue to try to solve all our way around. Ethnic disparities, income disparities on many fronts. And I guess the question is, we have had to suspend the point in time counts, and so are we comfortable with whether we're kind of going backward during the? I would assume that there are great pressures on the homeless population and to maintain this momentum in the middle of COVID-19. What are we doing to try to stay on top of it and to maintain this progress? I know that in the CARES Act, we funded a great deal of money to veterans homeless programs for exactly this purpose, whether it be allocated to emergency homeless programs or to keep people that were housed out of homelessness. Can you just update in kind of the COVID-19 world on where you think the progress of going after veterans homelessness is?
Thank you for the question, sir. You're right. I think without the PIT count, it definitely leaves a risk there, a sense of unknown. But I think I'm very proud of the work that we've done during the pandemic. I think we approached it as holistically as possible. There was obviously the need to truly focus on emergency housing. And so more than 24,000, again, hotel and motel placements to really make sure that we were decreasing risk of exposure. I mean, this isn't just about getting veterans off the street. It was also about making sure they were getting out of congregate settings, right? So their immediate safety was quite critical. We even established, of course, increased rates through the grant per diem program. We provided additional funding through SSVF in order to assure that we had navigators for the grantees. They could fund navigators to make sure the veterans were connected back to the VA, were connected to health services. Again, quite critical that we're looking at more than just their housing needs. A lot of the outreach that we did, unfortunately, had to be restricted because we didn't have a recent PIT count like you highlighted, but it was focused on targeting the homeless that we've at least have some record of, and then, of course, assuring homelessness prevention assistance where possible, again, through our grantees, our community partners, our facilities. We're reaching out to those veterans, making sure that if there were any concerns regarding family members, regarding employment, of course, if testing was needed, and we actually required testing with any enrollment in new housing services. And then, of course, the smartphone program, distributing more than 28,000 so that we could stay connected with them, so that their providers, their landlords, even their employers could be in touch with them, and more importantly, vice versa, so that they could reach out when indeed there was a need. So we really did run the full gamut of expanding services, of really reacting, I think, quite appropriately to just the increased risk over the last year. And it won't stop there. The goal, of course, is to get them into permanent housing, to get them employed, to prevent homelessness in the long term so that they have a sustainable path. And again, that's what that new Navigator program is. That's why we're really pushing, of course, our HUD-VASH vouchers. It's one of the more complicated programs that I've had the fortune of working with, but that complication just is a necessary piece to respond to the many factors that unfortunately cause homelessness. So thank you for the question. It's such an important point.
Yeah, and my time is just about up, but quickly, can you, no, I'm glad you were talking, not me. What are the gaps still? I mean, how do you know right now when a veteran has gone into a homeless situation where you didn't have any prior history? It was COVID related. Maybe it was not COVID related, but it was recent. I mean, how are you trying to reach those veterans that are off the grid and there's no way to find them right now?
Unfortunately, that is a huge gap that we will continue to work with our partners over at HUD. We'll work with public housing authorities, local governments, even our grantees who are receiving funding from us. They may have connection to veterans that we may not necessarily be connecting with in the facilities. I think this is, more than anything, not a problem that VA alone can solve. So we'll continue to partner and, of course, push as soon as possible for the next PIT count so that we can really get a better assessment of what numbers are out there.
Okay, thank you very much.
Thank you, Mr. Case. Mr. Case yields back. Mr. Valadeo, you're recognized for your 5 minutes of questions.
Thank you, Madam Chair. Thank you, Dr. Matthews, Dr. Hayes, Ms. Duke, and Dr. Carroll for testifying today. I want to take a quick moment before I start my questions to talk about a HUD Veterans Affairs Supportive Housing, HUD-VASH, which you noted in your testimony are key to preventing veteran homelessness. And it's going to follow up a little bit on what Congressman Case talked about. Several weeks ago, a constituent of mine who was a disabled Army veteran contacted my office for help with this HUD-VASH application. After months of frustration, he had applied for the program for a housing voucher in July of 2020. After he had informed, this was after he was informed by his landlord that home was going to be sold and he needed to move out. Nearly 3 months later, the veteran was issued a housing voucher, but the VA did not assign a housing specialist to help him find a landlord who would accept the voucher. These vouchers are only valid for 8 weeks, but the veteran was not called by a housing specialist for 5 weeks. During those 5 weeks without help, the veteran says he called and emailed the VA repeatedly with no response. Finally, when the housing specialist called him, she was shocked to learn that he'd had the voucher for so long. The housing specialist tried to find him a place to live in the remaining 3 weeks, but was unsuccessful and the voucher expired. The veteran immediately asked to reapply for the new voucher and was told that his application was being fast-tracked, but the holiday season seemed to have caused further delays. The veteran contacted our office in desperation on January 19th of this year, after a judge ruled to evict so the property sale could be finalized. We worked with his case manager to fast-track his application for a second voucher, which was issued a couple days later on January 21st, 6 months after the initial application. The next day, the veteran met with the VA housing specialist, who said he would spend the weekend looking for housing and would meet with the veteran on Monday to show him his options. But the housing specialist did not contact him on Monday. Facing eviction and homelessness, the veteran depleted his savings to purchase a travel trailer and moved into an RV park with his wife. A big ball was dropped in October when the VA did not assign a housing specialist to the veteran until 5 weeks into his voucher. That mistake has had serious consequences, the most serious of which is the eviction of a veteran's record going forward. In July 2020, the VA reported over 600 case manager vacancies. It was also reported that a significant number of HUD vouchers allotted to the Central Valley communities were going unused simply because the VA did not have enough resources to distribute them. To help, the Isaac Rowe Veteran Bill, signed into law earlier this year, requires the VA to contract out with vacant HUD-VASH casework services to local qualified community housing providers. Why has the VA struggled to hire and retain case managers, and what could be done to solve this problem?
Thank you so much for this question. That is definitely a very concerning and disappointing story, and I would certainly like to assist that veteran if you're willing to pass on information if there are still remaining concerns for him as an individual. I think really our issue with hiring is one that's quite complicated, that we indeed are working with our facilities to address. These as social work positions in some locations are quite difficult to fill. Particularly, it's a range of issues, particularly whether it's salary or whether it's location and expectations of travel as well. That is not an excuse, it's just a description. We are indeed working with the field to fill these empty positions and do recognize really the importance of case management. The voucher alone is of course not sufficient. I think it's also worth highlighting that even with case managers in some of our markets, unfortunately, there are other factors that prevent housing. And as you even said, when a specialist, although delayed and inaccessible, I realize, but when a specialist spent some time looking for housing options in that area, they still weren't available. We have some severe market factors that are addressing the ability for veterans to use vouchers. So we're working with our partners. We're working with even directly with landlords and communities to address that as well.
So how are you? I'm sorry, how are you, because I'm almost out of time, how are you identifying these local community housing providers to assist the VA with HUD-VASH program, and how will you notify these local providers for their eligibility to contract with the VA to distribute housing vouchers to homeless and or housing insecure veterans?
Yeah, our homeless program office staff at the individual facilities work with their public housing authorities for viable either future or current landlords, and that's how the information is distributed. It's through local partnership.
All right, my time's expired, but I would like to spend more time on this issue at another time. So thank you.
Thank you, Mr. Valadeo. Thank you, Mr. Valadeo yields back. Ms. Pingree, you're recognized for your 5 minutes of questions.
Thank you, Madam Chair. Thank you for holding this important hearing, and thank you to Dr. Matthews, Dr. Hayes, Dr. Carroll, for your team, for the important work you do for our veterans. We really do appreciate it. I know my colleagues have already brought up some of the concerns that I share. I appreciate hearing about the investment you're making in women's health, as the chair mentioned in the beginning. women's health really shouldn't be a specialty health. Women are a critical part of our armed forces and our veterans, and I'm glad to see there's more focus on that. And certainly the concerns people have been bringing up, the ranking member and others, about suicide within our veterans is really tragic and needs all the focus we can possibly give it. Unfortunately, in Maine, we have the highest suicide rate with our veterans in all of New England. So between that and mental health concerns, we're appreciative of the work you do and know how important it is. I might get a chance to talk more about those, but I want to bring up a topic that we're not covering right now, but it's a concern of mine, and that's related to the healthy diet and food as medicine. We have a lot of evidence available to us now that access to healthy foods and diets and eating habits really impact our health, and it's particularly true with many of our veterans. I worked some language into the FY21 Milcon VA report that encourages the VA to create a pilot program to provide produce prescriptions to our veterans in partnership with community organizations, something that's been successfully done with a lot of our medical providers, as well as in many insurance settings. Can you just tell me which office is responsible for this activity and whether any steps have been taken around that language?
Sure, yes, we actually do have a nutrition services offices that reports up through me, and they are actually quite excited about the pilot program. So they actually wanted me to express their gratitude.
Great. Well, thanks. We'll be following that, and greatly appreciate that you're already taking it on. I think it could be of help to a lot of people. So back to suicide, just a little bit about gun safety, which I know can be a challenging topic, but we have a huge coalition in Maine that are interested in this. Last year, the Maine Bureau of Veterans Services created a Maine Safer Homes Task Force to promote firearm and medication safety in an effort to prevent suicide in Maine. They're taking a public health approach to combat our suicide rate, and includes a broad coalition: the gun ownership groups, the VSOs, our CDC, and the VA system. The report on the Milcon VA bill includes a provision encouraging the VAA to collaborate with states on gun safety and gun storage, as we are doing in Maine. Is there any office within the VHA that is taking a coordinated approach to these collaboration and to share best practices?
Yeah, thank you, ma'am. This is David Carroll. I'll take the question. As members of the committee have already said, suicide prevention is a national public health problem. It is not something that VA can tackle alone, and it requires a public health approach. And it's everyone's business, to your point. Those are some of the core tenets of our suicide prevention program. And we are working very pleased to hear about the effort in Maine. That is exactly the kind of program that we are trying to foster through our regional programs, working with VISNs and regions in the country to advance suicide prevention and social connection for veterans in their communities. By veterans, for veterans. It's part of our Governors and Mayors Challenge programs to enable those groups to look at their own state or local data so they can inform their approaches. And as part of that, we have developed a toolkit, a program, if you will, on suicide prevention is everyone's business, a toolkit for safe firearm storage in your community. And it is about safety. It's about and so happy to do it that way. Also, as you said before, working with VSO groups and other private groups, to advance safety in this area.
Great. Thank you for that. Again, we appreciate the work you're doing. And I like the slogan that it's everyone's business, because it's certainly something that we all have to acknowledge. Just quickly, with the time I have available, I had a meeting recently with one of our veterans groups, and they expressed some frustration that mental health activities were only being provided via telehealth and not available in person. I know we've had so many COVID restrictions, and frankly, many people suggest to me that having telehealth available for mental health services has been beneficial. But I was just curious about, Are those restrictions changing? Is that a requirement of the VA right now, or just where are we with that? And I don't have much time, so just quickly, if you can.
Yeah, very, very quickly. There is no prohibition against in-person care. I want to make that clear. We have seen a rapid shift to the use of virtual care, telemental health over the past year, and we've been successful at doing that, both making veterans comfortable with that as well as our providers. But we have always maintained the ability, based upon the individual's need for what they need. In some cases, it may be they need to come into a facility because that's the only way we could provide care, such as a comprehensive neuropsychological evaluation. But the driving factor in all of this is safety and looking at the infection rate in the local community and empowering local leaders to make decisions that are going to make sense for their facilities.
Great, thank you. I'm appreciative that you have that flexibility, and I yield back, even though I have no time to yield back. Thank you, Madam Chair.
The gentleman yields back. Thank you very much. Mr. Rutherford, you're recognized for 5 minutes to ask your question.
Thank you, Madam Chair, and I thank our presenters today for some great things that are obviously going on within VA. I mean, I've looked at these reports and very encouraged by some of these numbers. And when you look at, as my colleague, Mr. Case was talking earlier about the homelessness, I know one of the driving, or two of the driving factors in a lot of homeless cases is severe addiction and severe mental health issues. And I see some drop in the opioid, and I think is a direct result of the complementary integrated health system. And so I applaud you on that. But pardon me?
Sorry, Mr. Rutherford. Judge Carter, you may want to hit mute.
Oh.
And I hope you're okay.
Oh, I thought I was. Sorry about that.
That's okay. I was just getting concerned about you. Sorry, Mr. Rutherford.
That's okay. Thank you, Madam Chair. So my question is this: when we look at the 18 flagship locations for the Whole Health Initiative, and what I didn't see was the mental health gains, which means a drop in mental health occurrence or suicide occurrences. How much of that reduction is actually in those 18 flagship locations versus the rest of the country? I didn't see that in the report, and I'm curious whether that whole health, because I believe in that, and I'm curious whether that whole health approach is responsible for some of the reduction we see, number one, in opioid addiction, and then sort of the reduction of mental health or suicide in those cases where they've sought care with VA in the last 2 years. Do you have any anecdotal information on that, Ms. Matthews?
Definitely. Actually, it's more than anecdotal. The 18 sites, the study that we did of those pilot sites actually shows a 3-fold reduction in opioid utilization when they actually compared the veterans who were using the whole health approach versus ones who weren't. So we know this was a direct causal relationship, and we're very excited about that. And then there's even broader decrease that we've seen, again, when using whole health at a even more increased utilization, 8 or more visits. They saw a decrease of opioid use by 38% compared to those who didn't use it. So we're actually quite ecstatically focused on this as a solution. We obviously need to take care of the whole veteran, address their concerns, address their pain, make sure that they, as well as we as a partner, are looking at their whole being. But just the benefit for opioid use is exactly great. What I don't have, unfortunately, is data on suicide prevention yet, but I do assume that's coming. I think we need to look at that data for a little bit longer period of time to make a conclusion.
Okay, and to follow up on the suicide piece just a little bit, I know the study just came out on service dogs, and as you know, or may know, I have a bill, the PAWS Act, which would provide for VA to offer service dogs to veterans with who are diagnosed PTSD or DBI, and from what I understand, the report is now complete. The findings are encouraging that it, in fact, does reduce suicide among these veterans who are suffering. Can you tell me when we expect the final report to roll out? Because I heard something about they're not quite ready to say, let's start, giving dogs out.
Right, Dr. Carroll, can you speak to the actual study report?
Sure, Dr. Matthews. And
Oops, you went on mute. I believe.
Thank you. Thank you for the question. We are working with our colleagues in the Office of Research and Development to make sure that the findings of the report get distributed. And I think there are multiple issues here. One is we want to provide the support that veterans need in the manner that is appropriate for them, which may include for many a service dog. Also thinking about taking care of that animal. But it's also about ensuring that veterans have access to a comprehensive program of treatment across the board and that it's integrated with everything else. I think the long-term consequences, such as you mentioned in your question around suicide prevention, I think we need to study that more and see what the long-term consequences are. But I think certainly eager to go forward in expanding support in this area.
Good, thank you. Madam Chair, if I could, I see my time's up. Since I had a couple major interruptions here, you mind if I just make a statement?
No, go ahead. Go ahead.
Very quickly. Thank you. Thank you. I just wanted to respond to something that Ms. Hayes said earlier about the DOD policy being antiquated on the fertilization services. And I just want to make the point that there are many who would tell you that that's not antiquated, that is in fact common sense and morally correct. So and we're talking about public dollars. And so I just want to make sure that she understands there is another point of view on that. Thank you, Ms. Mays. I yield back.
Thank you, Mr. Rutherford. We can live to have that further conversation another day. I'm quite sure we will. Mr. Rutherford yields back, and Mr. Trone, you are recognized for your 5 minutes of questions.
Okay, thank you, Madam Chair. This has been great information. We really appreciate it. Dr. Matthews, great work on the whole health program. It really sounds promising. Let's go back to what Congressman Pingree was talking about a while ago on suicide. 17 vets a day are dying every single day. 6 of those vets had accessed VA health care in the previous 2 years, which means 11 had never accessed any health care with the VA. And, if we don't change something, we're going to keep losing majority of these folks every single day ongoing. So what I'd like to know is what's needed to reach out to the vets that are in crisis sooner? And is there any differentiators between the ones that reach out, the 6 that we talk to every single day, or the 11 that never sought help from the VA? And can you see any patterns, age, geography, race, income levels, to give us some indicia of how we can help these folks?
Before I allow Dr. Carroll to speak to some of those data questions, because those are so critical to make sure that we're paying attention to very particular groups of veterans. I think it's worth highlighting, yes, those 11 that have not accessed VA services, that's where our focus on both clinical interventions as well as public health interventions is so critical. We need the broader community. We need those partnerships with the states, with the mayors to truly reach out and make sure that we are reaching those veterans regardless of whether they're coming to the VA or not. This is so much bigger than us. But Dr. Carroll, do you have some information on the data that the Congressman was asking about?
Thanks, Dr. Matthews, and appreciate your question, Congressman. And we'd be happy to sit down and do a deep dive with you or with members of the committee at any time on the suicide data. And in your limited time, I will try and make some brief remarks. I think to the point that Dr. Matthews was making, we need the clinical interventions within our healthcare system as well as community-based interventions to understand those 11. And actually, as we have looked at the data, one point is that we know that probably about 2 of those 11 every day have had previous contact with VA. But perhaps they haven't had any VA healthcare over the last 2 or 3 years or longer. And so part of our program is to look at things that we can do right now. And one of the planks in that program is to look at prior VHA users and to also to stratify, to go back to the point earlier about artificial intelligence, to stratify within that group of those who we think may be at greatest risk and to reach out to them and perhaps get them engaged in care. But we know there are veterans who are going to choose not to receive health care from VA. And so our community partnership programs are working with states and mayors and other community groups, the veteran-to-veteran groups. We have many public-facing resources that provide trainings for community providers. We have a consultation program for suicide risk management, for post-traumatic stress disorder that are available to community providers, not just VHA providers. And they make use of it, which is the good news. So I think we're really trying to both support the work that we're doing within the VA, as well as supporting the work that's going on outside of the VA, both in other healthcare systems, as well as in the community writ large.
Just quickly there on following up on the community, and I agree with you completely. We've really worked hard on expanding the CCBHC, community-based behavioral health centers. And there's been a pilot project. We added more states, and then we drove more funding into it here with COVID. And I think it's critical from a lot of vets that don't live near a VA hospital can go to the certified community behavioral, health center, or it's urgent and they don't have time to schedule, so they can go there quickly. But how do you collaborate with the certified community behavioral health centers?
So I think we're interested in collaborating with any community provider, and I think probably the way that we touch them most readily is through the public-facing materials that we have, and working certainly through our community care programs to make sure that providers in those programs have access to the same training materials. I think we work. We're talking today about specialized areas within VHA, such as women's health, mental health, suicide prevention, homelessness. But the reality is that on a day-to-day basis, we work very collaboratively. And my point here is we work very collaboratively with our homeless program providers and our workers on local levels and nationally who are in the community, who have those touch points, community-based care management touch points. And we work and have our community of practice calls focused on working broadly in the community with other communities of practice.
I know my time's expired, but I just would suggest we're really blowing up the amount of certified community behavioral health centers all across the country. I've been working with Senator Stabenow on this, and that would be an area I think it's changing quickly that you should work on. So proactively reaching out and connecting so we can better help our vets in these areas. Thank you.
Thank you, sir.
Thank you, Mr. Chone. The gentleman yields back. And now, Mr. Gonzalez, you recognize for your 5 minutes of questions.
Thank you, Madam Chair. As you know, the CARES Act provided $19 billion in supplemental income to the VA, which as of last month, $10.9 billion remains available this week with the passage of the American Rescue Plan. An additional $17 billion was appropriated. Of that, $13.5 billion was set specifically for suicide prevention, women's health, homeless programs, and telehealth. So there is an ample amount of resources available. Women make up of approximately 10% of all United States veteran population. Last year, the MILCON VA appropriations bill was around $90 billion. Of that, $660 million were for women specific. That's less than 1%. We've got over 10% of the population women, but less than 1% is spent on women. I understand that, some of the same accesses of care, go to both men and women, but is there anything in particular that we can work on that can help specifically for women? And that's Dr. Hayes. Anyone that can answer it in particular.
Sure, I'll jump in before Dr. Hayes can definitely add anything. The one point I do want to clarify, the funding that is spent on gender-specific activities, of course, are those services that only women can seek out, right? Mammograms, gynecology, infertility, maternity care. That in no way it means that there aren't other funding spent for the other multitude of services that women veteran need. So I would like to state that it is not necessarily just that portion of funding that is spent on women. It's spent on those services that are needed that may not necessarily equate to that same proportion of 10%. But Dr. Hayes, do you have anything to add there?
Certainly, Congress generously has provided that portion of the budget for women. In addition, in 2021, we were allocated special purpose funds because we had gone to the leadership in VA, and we've developed a plan. In October, we sent out $40 million specifically for hiring and equipment for women because we had done a deep dive on what was missing. And that is buying us about 400 providers right now. In addition, Congress in the last appropriation did give the $35 million additional targeted funds for women. We are frankly scrambling a little bit right now to make sure we have another RFP, which will go out next week to help fill any additional gaps in FY21. We also expect that we'll be able to put out special purpose funds at about that magnitude. So we're talking 75 to 85 million in the next couple of years, because what the field has let us know is that these positions that they're hiring right now, they need to be able to have those positions in place over the next several years. So that is our commitment from VHA and the CFOs on right now to be able to speak to that if needed.
Great, thank you. Thank you for that. The VA received $971 million for the VA homeless program with the CARES Act. With the American Rescue Plan, they've received, or they're about to receive $5 billion. Once again, ample amount of resources there. My question is, how much money remains in that program from the CARES Act?
So this is Laura Duke, and just to clarify, sir, you're asking what remains from CARES that was specifically identified for the homeless program?
That's right. Out of the 971 that was appropriated.
Hang on, I'm pulling that up for you right now. But just to clarify, sir, with the American Rescue Plan, there is significant funding for veterans' health provided to include these services, but also in addition to these services, so just general care being provided. I apologize.
I'm essentially, I want to highlight that there is ample resources available, and it's not really the resources that's in need right now. What is need is the actions and the programs, the successful programs that are working. On that note, and I'm almost out of time, 3 states meet the U.S. Interagency Council of Homeless benchmark. Only 3 states. So we have a lot of work to do here. My question, and it can go for the record, where is Texas on this benchmark?
Sir, just to answer, we've obligated 828 million of the 971 million in CARES for homeless.
Perfect. Thank you for that. Madam Chair.
Sir, I'll definitely get back to you on Texas. I'm not tracking that currently, but I will get you that answer.
Thank you. The gentleman yields back. I do just want to clarify, though, Mr. Gonzalez, and I know that this was prior to your service, but the 13.5 billion that you mentioned from the CARES Act included those areas that you mentioned, but were not limited to them. So, I mean, that funding that we provided was much broader for all VA medical care. And it includes the ability for the VA to utilize those funds for those purposes. And then there was not a $971 million appropriation for homelessness, specifically in CARES. That's what VA chose to allocate towards it from the total amount that they received. So I just wanted to make sure that we were clear and also confirm with head nods that I'm characterizing that accurately. Okay, great. Thank you. Ms. Lee, you're recognized for your 5 minutes of questions.
All right, thank you, Madam Chair, and I really appreciate having this important hearing today. And I thank all the witnesses for all your work that you do with veterans and for being here. We've talked a lot today about veteran suicide and those who die by suicide, and you know, the 5.8 deaths per 100,000 is definitely too high. We know that one veteran suicide a day is way too much, and so acknowledging our goal must be to bring that number to zero. I wanted to talk about my bill, the Leave No Veteran Behind Act, that was signed into law as part of the Veteran Compact Act. This bill requires the VA to seek contact to covered veterans to encourage them to receive comprehensive physical and mental health exams. And this really plays off of what Congressman Trone was discussing with you. And I wanted to ask Dr. Carroll, it's been over 90 days since the Compact Act was signed into law. And could you give us an update on how the implementation is going, specifically about outreach?
I'd be happy to, and appreciate the question, and appreciate the act that was passed, and we share the mission and the imperative that you've laid out for us. So I think the bottom line is we are still in the planning phase. I mean, this is going to impact potentially care and veterans in multiple good ways, but I think the complexity here has to do with the proper messaging to veterans in terms of the opportunities that are available to them that are there. They may vary from individual to individual in terms of what is actually appropriate or necessary or in their best interest, and the opportunity for us to work with each individual veteran and to set up a process so that we can do that. And then also in terms of thinking about the emergent care provisions in the Act, and making sure that the expectations for our staff are clarified, because there are multiple touch points, whether it's through the Veterans Crisis Line, whether it's through a VA facility emergency department, or some other role. You know, what exactly is the role of each individual in that part? And in regarding the provisions where VA would be expected to pay for care that is provided outside of VA to someone who is not currently enrolled in VA. There are multiple moving parts, if you will, ma'am, and we're trying to, we have work groups assigned to the different provisions in the Act, and we're moving forward with the planning. But I'll also defer to Dr. Matthews if she wants to add anything to that.
I agree with you. Just to add in, I think a great deal of the concern of course, Congresswoman, is how we can best track that this is occurring. We are doing a great deal of outreach right now to veterans across the country for vaccine administration. So those touch points are equally as critical. And a lot of this outreach, even indeed by some of our whole health staff at some facilities that we're hearing about, is to ask them if they're enrolled in primary care, to ask them if they're receiving mental health. So while we may not necessarily have the structure to measure and be able to report out quite yet, that's what a lot of the planning is around. We know for a fact, and unfortunately more anecdotally, that within the vaccine outreach that we're doing, that we are touching a great number of veterans, including those, we've actually seen increased enrollment as veterans are seeking out VA to receive the vaccine. So even a better conversation, do you have primary care? When was the last time, you talked to someone about your mental health? Are you interested in whole health? We're having the broader conversation. So we thank you for that bill, because it really does mirror exactly where we want to go.
Thank you. And, I would just add that coordinating during the transition, because as we know, transitioning veterans have an increased risk of suicide. So I'd love to see a little more put on coordination with the Department of Defense. And I know that gets a little tricky, but my time is up. So I yield back, and thank you both.
Thank you, Ms. Lee. The gentlelady yields back, and Mr. Christ, you're recognized for your 5 minutes of questions. Mr. Christ, you need to unmute.
Thank you, Madam Chair. I appreciate the prompt. So I wanted to ask to Dr. Hayes. In my home of Pinellas County, Florida, we're blessed to have a very robust women's veteran community. And I have heard firsthand some of the challenges being faced there, especially a lack of women doctors and medical professionals. So I guess my question to you would be, what are your plans to recruit, incentivize, and retain more women providers? Please.
Mr. Chris, thank you so much for that question. We have noted that in some areas of the country, we do have recruitment difficulties. That's one of the problems, but we have set up essentially a tiger team with VA Workforce Management and Recruiting Office to do a number of things, including outreach to physicians in the community, working with medical school graduates, et cetera. We have a full plan on that. We also, part of what I spoke about a moment ago about making sure that the field, the VA facilities are fully staffed as they should be, is that right now they can seek monies from us. We're giving them the funding to be able to hire. So one of the barriers in the past, I think, has been that facilities were kind of juggling this and if they didn't think they had enough women to support another full position, maybe they weren't going for it. But right now we're telling them, hire up, ask for the money, get the position in place. And because we know that by the time the position is in place, we're certainly going to have enough women for that provider to see. So it's a combination of an issue of not looking for the providers and right now encouraging the field to hire, and also working on these recruitment issues. And we do have a full recruitment staff, essentially headhunters at the national level, that when a facility says we can't seem to hire the women providers that we need, that they can turn to them for that support, and they'll go out and actually look for providers, incentivize it. We have the ability to have people relocate. We have hiring incentives, and we're trying to educate the field about all the incentives that we have to be able to get people in place.
Okay, well, thank you very much. So beyond the issue before on providers, what are your biggest needs for women's health, and especially military sexual trauma?
I think the challenges in the field have been that we've been slow to respond to the fact that we have so many women coming in. And from leadership on down, we've had to make sure that people recognize we need a full program of outreach. As we were talking about just a moment again, how do we reach all these folks? We've been calling women through the Women Veteran Call Center. We've called over 1.6 million women, encouraging them to be part of their VA benefits. Military sexual trauma is an experience of about 25% of our women veterans in the country. And so a considerable amount of the outreach that we're doing is to make sure that we let women and men know that we have the right services for them at the VA. You'll see a lot coming out. April is Sexual Assault Awareness Month. you'll be seeing that particular effort. And in addition, we have a new women's health transition training program where we're working with service members, women service members. There's a special course in the TAP program so that they are directed to the kinds of services that VA has, and that they recognize that we welcome them for dealing with the issues of surviving military sexual trauma.
Great, thank you very much. And I can't see how much time I have left, but I only have one more question.
You have a minute and a quarter. You're good.
Okay, thank you, Madam Chair. My dad was a physician and my sister's a physician, but I can remember going on house calls with my dad as a kid. Reading the VA's whole health initiative seems consistent with that personalized type of approach, which I think is incredible and matches what we see in healthcare outside the VA. So if you could please provide an update on how this is being implemented, I'd be grateful.
Great. Thank you so much for that question, sir. Yes, we are expanding beyond our 18 flagship sites. They've gone successfully, as we discussed earlier, with decreased opioid utilization, improvement of sense of meaning, of sense of purpose, and we're very excited about that. So we've moved on the rollout to the additional 37 sites. However, I'll caveat that's more the formal program. We have sites across the nation that are eager for this, that are making those really purposeful decisions to have resources for veterans so that they're concerned, that they're addressing their well-being. They're referring for additional resources in the program that perhaps aren't necessarily officially started at their site. So I don't even want to give you that 37 number and make you think that that's the only expansion that the program has gone, but those 37 are part of the formal evaluation. That's why we describe it. But I think even more so, I mean, the last year has taught us a great amount about how we as an integrated system need to obviously address care in telehealth and address larger public health concerns. So even through whole health, we've expanded a great deal of really self-care opportunities through our blogs, through our websites, app modules on the phone. It is perfectly primed, kind of this shift to telemedicine, to also expand whole health resources. And we've had a great deal of uptake with 30,000 some views of different websites over the last year. So whole health is really broader than just what physically is being provided, what services are being provided in the facility. And the pandemic, unfortunately, as a silver lining, really helped us push those resources out.
That's great. Well, listen, thank you so much. I appreciate that answer. And Madam Chair, I yield back, and thank you.
Thank you so much, Mr. Chris. The gentleman yields back. That concludes our first round. I have a couple of quick follow-ups, and I don't know if anyone remaining. Judge Carter, I'll just proceed through the order of the remaining members, and after I'm finished, and then we can wrap up. My follow-up question is on military sexual trauma, and I wanted to see if Dr. Carroll could answer that question as well from the mental health side, because obviously dealing with military sexual trauma crosses both physical health care and mental health care.
Thank you, Madam Chairwoman. And yes, it does. And it is an experience that affects a whole person, and both mental health and physical health. And as Dr. Hayes says, this is a problem that affects both men and women. And I think which is why I think we have a strong foundation in VHA to provide integrated care. We screen for military sexual trauma. That's part of our standard screening across primary care and our mental health clinics. We and then engage, refer that person into care, appropriate gender sensitive care that's evidence informed. We also work very closely with our vet center partners, because we know that sometimes veterans, or in some cases active duty service members, may be seeking services for military sexual trauma, but may not be coming to a VHA facility. And so I think the training resources that we have for providers to make sure that they're able to provide this level of care, apply both within the VHA facilities as well as our vet center partners.
Thank you very much. The other question I had is really about some of the revelations that came from the January 6th attack on the U.S. Capitol. We've seen a lot of reports highlighting how many of the attackers were veterans. And there's been really a growing recognition that the military has to do more to address extremism in its ranks. Obviously, once they are no longer active duty, they become veterans and they're in your care oftentimes. Is this an issue that VA's mental health programs has started looking at as well? And then is there anything that VA is doing to look out for and address extremist tendencies among veterans who seek mental health services at the VA? Dr. Carroll?
Yeah, I'm going to, if I may, ma'am, I think that this is an emerging area, and I think we share that, and I think we're trying to understand more. The process, though, that we do have in place, and actually that we were able to push out after in early January, has to do with the fact that mental health providers are every day in a situation where they have to talk about difficult issues. You know, whether it's family violence, whether it's difficult behaviors, whether it's extreme views. They have to talk with veterans. They provide a safe and welcoming space for veterans to work through those issues. And the provider and the veteran may have different opinions, and I think so we try and support our providers to make sure that they feel comfortable having difficult conversations with veterans when there may be a difference of opinion, as well as to help veterans think about the whole life that they have, not just thinking about, you know, a particular issue, but as Dr. Matthews has said several times today, really having a whole person, a whole health perspective, which means how are you living in your various communities and what's your experience in those communities, and how could we help you improve your relationships within those communities.
Okay, that's a little bit too generalized of an answer when I was focused more on extremism and what your, you know, whether your mental health programs have started to look at that more specifically. So if that's more than you're able to answer here.
I'd be happy to get back to you. I mean, it's with that lens, I'm sorry, but it's with that lens that we're going down that path, but we'd happy to get back to you with a more specific focus on extremism. Thank you.
Thank you, I appreciate that. So that concludes my questions. Judge Carter, do you have any additional questions?
Just one more. Fundamental components of national suicide prevention strategy is that everyone, from the federal agencies, states, communities, organizations, to families, have a role to play in preventing suicide. How does the VA harness the outreach and boots on the ground capacity offered by the VSOs, such as the American Legion's Buddy Check program, to reach the veterans who are not receiving care from the VA? Is VA a partner in the American Legion effort? And does VA coordinate with suicide prevention, nonprofit organizations, and veteran service organizations? And how does this coordination occur?
Yes, sir. And the short answer is yes. We coordinate and communicate all the time with American Legion and with other veteran service organizations, particularly in the area of suicide prevention and mental health care. VA is also a member of the National Action Alliance on Suicide Prevention, working with other federal partners, other private partners in this space, and the folks from the veteran service organizations help inform and guide our outreach campaigns. It's mutual. I work very collaboratively with them on the outreach that they're doing. They pass along our training resources on how to talk to someone if you are concerned that they may be suicidal, and how to get them into care. So our training resources are something that we provide and help them incorporate those into the work that they're doing.
When I was a judge, we built a drug and alcohol treatment center in our county, and it was actually very successful. One of the things I think we learned through experience is that those people who had a fallback position of somebody they could go to in aftercare, after treatment, are the ones most likely to be successful. Head and shoulders above people who went back to where they had been, no backup, no body checking on them, nobody working with them in aftercare. They tended to fall back into bad situations. And that's why when I read about this American Legion buddy check program, it looked like a great idea. Soldiers and sailors and airmen, Marines, their buddies are important to them. It's the world they fought in. And I encourage you to work with those people, and I'm glad you do. Thank you. I yield back, Madam Chairman.
Thank you, Judge. Gentleman yields back. Mr. Trone, you're recognized if you have additional questions. Mr. Trone, I see you there.
Mm-hmm.
I'm not sure if that's a picture of Mr. Trone or if he's actually frozen. Okay, well, since he's not responding, Mr. Rutherford, Mr. Valadeo, do you have any additional questions?
No, I do not. So thank you, Madam Chair, for hosting this. I think today was a very informative one, and I'll have some more questions for the record later. So thank you.
Okay, great. Thank you so much. Mr. Rutherford?
Thank you, Madam Chair. I would like to go back to the issue of the MSTs, and one of the interesting numbers that I see here is there's concern that the VBA policies are not properly or that these cases are not being properly adjudicated according to the VBA policy. Now, and I understand when it gets to the VA as a disability claim, one of the things that just jumped out at me is the issue denial reason being not incurred or caused by service, which means there is no corroborating evidence, including markers of the claimed in-service MST stressor. But I do understand that there's some training going on to try and capture these stressors. Ms. Matthews, can you tell me more about the success we're having in training on capturing? If we don't collect the evidence, we're never going to prosecute the crime. And we're never going to be able to provide the service for PTSD as a result of MST.
Excellent question. If you'll allow me, sir, to defer to Dr. Carroll on that training around MST.
I think this is Dr. Hayes. I think what he's referring to actually is an advanced training of the VBA rating specialists, which we would have to get additional information back from VBA. Because in the VA side, we do support through our mental health folks, the individual to be able to get to the point of filing a claim and going through what can be a stressful claims process. But then the technical aspects that the Representative Rutherford is asking about belong to the VBA side. Perhaps we could take that for the record.
Yeah, and Ms. Hayes, I just want to make sure that we are educating the VBA on what those elements are that you guys need on your side. Because if they're not, that's why I was saying, if they're not collecting the evidence up front, then it's never going to get to you in a form where we can actually provide assistance for these folks.
I think you're absolutely right, sir. And I think you'll also see emerging very soon some more information about new activities at the Department of Defense to go forward on this issue and to make sure how the reporting is done and all the things that you're raising about what happens when someone's on active duty and they experience military sexual trauma. So I appreciate your point here, sir.
Thank you. And I'll be trying to follow that in the future, because I think that's the core of the problem, or part of the problem anyway. But I think it's a big piece of it. So thank you. With that, Madam Chair, I will yield.
Thank you so much. Gentleman yields back. Mr. Trone, I'm not sure if you can hear me, but do you have any additional questions? Okay, I did see him move, so all right, well, I'm assuming that he does not. That concludes, I don't believe there are any other members that are still with us that have not asked a second round of questions. So that concludes this morning's hearing, which is now bled into the afternoon. I want to thank our witnesses for participating in today's hearing, and we look forward to continuing to work with you on these issues on an ongoing basis. I do expect that we will have another pre-budget hearing likely the week of March 22nd. And so we'll let you know as soon as that is scheduled. And with that, the hearing is adjourned. Have a good weekend, everyone.